Hi guys, welcome back. As usual, we're going to start with a question. So, a 36-year-old man who has history of Crohn's disease has been taking adalimumab, right? Adalimumab is a monoclonal antibody against TNF-α, which is tumor necrotic factor alpha. Therapy for the past 4 months. Now, the patient is having 3 weeks fatigue, weight loss, and a persistent non-productive cough. On examination, he has bilateral crackles in the upper lung fields. So now we did a chest x-ray, and that chest x-ray shows cavitary lesion in the right upper lobe. So the sputum sample reveals slender acid-fast bacilli. So acid-fast bacilli, one of our differential will be what? Will be tuberculosis. So putting this together, so somebody who is on adalimumab, which is anti-TNF-alpha, that's having some B symptoms, right, along with productive cough, and then in addition to that, we see cavitary lesion in the lung along with acid fast. So this patient has tuberculosis based on this presentation. And the most likely reason why this patient has tuberculosis is most likely because the patient has a latent TB, latent tuberculosis, and it was started on this medication, thereby causing reactivation of his latent tuberculosis. So which of the following immunologic processes was disrupted by this patient's medication and most likely contributed to the development of his current condition? As you know, TNF normally maintains the granuloma, right, in the latent TB. So if this patient is taking a drug that is inhibiting this TNF, so that could cause breakdown of those granulomas. So the best answer there will be C, right? So interferon gamma activation of the macrophages. So let's see why. So in the previous lecture, right, we started talking about necrosis, which is a form of cell death, right? And then we've discussed coagulative necrosis, liquefative necrosis, and in this lecture, we're going to talk about caseous necrosis. But since we're going to be talking about caseous necrosis, we can as well also talk about granulomatous inflammation, because caseous necrosis is also a form of what? A granulomatous can happen in granulomatous inflammation. So after we talk about granulomatous inflammation, then we're going to talk about caseous necrosis. So when we look at granuloma, so granuloma by definition, so granulomatous inflammation is a form of chronic inflammation. And this occurs when the immune system tries to wall off a particular infection. So if they can't kill the infection, but they can wall it off and then form a granuloma in that area. Or if somebody have a foreign body, that could also lead to granulomatous inflammation. So what is granuloma? So granuloma is a small organized collection of activated macrophages. So when this macrophage gets activated, right, then this macrophage now, they're going to now form what we call epithelioid cells. So the reason why they call them epithelial cell is because it looks like what? Epithelia, right? So they're going to form all this collection of epithelial cell. And also around there, we could also have some macrophages that fuse together. So those macrophages that fuse together, right, we're going to call them multinucleated giant cell, right? And around there, we're also going to have our T-EPA1 cells, because T-EPA1 cell also involved in the activation of this macrophage. So our T-EPA1 cells, which we're going to see in a second. And then because of the chronicity, then fibroblasts will also be seen around the granuloma, because the fibroblasts will start to make what? Fibrosis, right? And of course, as this continues to go on, because it's a form of necrosis, and with the chronicity, calcium could deposit there, right? So, and that could lead to what we call a form of dystrophic calcification. So that could cause a form of dystrophic calcification, whereby there's deposition of calcium in a necrotic tissue. And that's what we see with what? granuloma. And like we mentioned earlier, it's a defensive barrier to contain a persistent pathogen or irritant. So moving on. So the next we're going to talk about what are the causes of granuloma. So we divided the causes of granuloma into two. So we have the infectious and we have the non-infectious. So let's start with infectious. So under infectious, we have bacteria. So bacteria like Mycobacteria tuberculosis, which is a classic, most classic. We have Mycobacteria leproi. We have Listeria monocytogenes, right? And then Listeria monocytogenes, like we know, it can lead to spontaneous abortion, right? Because it can cause granulomatosis infanti septica, right? We also have Bartonella ensler, right, which could lead to cat scratch disease. And in cat scratch disease, they could have lymphadenopathy, so the lymph node could be swollen. So when you do a biopsy of the lymph node, you're going to see the stellate or the star-shaped necrotizing granuloma. Also, in tertiary stage of syphilis, remember syphilis is due to Treponema pallidum. So in tertiary stage of syphilis, one of the things that we could see there is granuloma, which is called Gorman, right? So that could be seen in these patients. Also fungal, right? Particularly systemic mycosis, example like histoplasma, right? Blastomyces. So all this, they could also cause what? Granuloma. Also parasites like schistosoma, right? Hematobium. So that could also lead to granulomatous formation. So patients who also have chronic granulomatous disease, right? Remember, chronic granulomatous disease is due to deficiency of NADPH oxidase. So because this patient, they don't have NADPH oxidase, right? They can't form what? In their respiratory burst, right? So they will not be able to form superoxide. And if they can't form superoxide, they can't form hydrogen peroxide. And if there's no hydrogen peroxide, they can't form bleach. Remember, the bleach is HOCl, right? By the help of the myeloperoxidase. And this bleach supposed to kill the bacteria in the respiratory burst. So if this patient have NADPH oxidase, then their only hope that they could rely on the hydrogen peroxide that is coming from the infection. So they can take the hydrogen peroxide from the bacteria and use it to form bleach to kill the what? To kill the bacteria. But some bacteria, they are very smart. So they have catalysts. So they're going to use that catalyst to break down the hydrogen peroxide so that the patient will not be able to use the what? Hydrogen peroxide. So that's why patients who have chronic granulomatous disease, they are more prone to what? Catalyst positive organism. Example like Staph aureus, right? Or Aspergillus. So because of that, because they can't kill this pathogen, so that means those pathogens inside their inflammatory cells, at the end of the day, they can form a granuloma and wall off those infections. So that's why this disease is called chronic granulomatous disease. And then we also have the non-infectious causes of granuloma. So we have the immune-mediated, example like sarcoidosis, right? Crohn's disease or subacute thyroiditis or granulomatosis thyroiditis. We also have rheumatic fever, right? Like ash cough body. So in rheumatic fever, we see ash cough body, which is granuloma with giant cell. Vasculitis could also cause granuloma, so like large vessel vasculitis or small vessel vasculitis. So under large vessel vasculitis, we have the giant cell temporal arteritis or Takayasu arteritis. Under small vessel vasculitis, we have granulomatosis with polyangiitis, which is called Wegener's, and we also have eosinophilic granulomatosis with polyangiitis, right? And these are the patients that classically have asthma vasculitis, right? And foreign body could also do it, so like things like beryllium, which could cause berylliosis, inhaled antigen, which could cause hypersensitivity pneumonitis. Sometimes we call this what? Farmer's lung, right? So that's sometimes we refer to as farmer's lung. And to mention, sometimes hypersensitivity pneumonitis is not, because the way we form granuloma is a form of type 4 hypersensitivity reaction, as we're going to see in a second. So in patients who have hypersensitivity pneumonitis, they also have some component of type 3 hypersensitivity reaction, which is immune mediated, which we're going to cover later under immunology. Also, causing Sarcoidosis could also do it. And a suture. So if somebody have a suture in place that is not being removed, that could also lead to granuloma formation. Moving on, guys. So let's talk about the mechanism of how granuloma is being formed. So how do we form granuloma? And this mechanism is the same for every granuloma. So the best way to start, let's start with the classic one, which is Mycobacteria tuberculosis. So let's say somebody was exposed to Mycobacteria tuberculosis. So let's draw the Mycobacteria tuberculosis. Let's say this is the tuberculosis, right? So let's say that's Mycobacteria. So this Mycobacteria now, right, is going to now release what? Is going to be producing antigen. So antigen will be released, right? And this antigen now is going to now be phagocytosed by the antigen presenting cell. So the antigen or APC, so antigen presenting cell, is going to phagocytose those antigen. And what are the example of antigen presenting cells? Example include macrophages, right? Macrophages is an example. B cells, right? It's also an example. Dendritic cells. So all these are example of what? Antigen presenting cells. So they're going to present the antigen to T cells. So here we're going to use what? We're going to use in the lungs, since we are talking about Mycobacteria tuberculosis. So if they inhale it, it's going to go to their lung. So here we're going to talk about alveolar macrophage, right? So alveolar macrophage now, what it's going to do is going to phagocytose this antigen. So this alveolar macrophage is going to phagocytose this what? Antigen. And then once it phagocytoses it, that antigen now is going to go into what? Inside the macrophage is going to go into what we call acidified endosome, right? And then right inside the acidified endosome, right, that antigen will be loaded into what? Will be loaded into MAC class 2. Remember, on antigen presenting cell, all the antigen presenting cells, they normally they can express MAC class 2. And that's what they're going to use to present that antigen. So this MAC class 2 now is going to now move to the surface of the cell with the what? With the antigen. So you want to move to the surface of the cell with the antigen, right? And as we know, MAC class 2, right? So the MAC class 2 normally presents its antigen to what? It presents its antigen to T-helper cells, right? And then these T-helper cells, they have CD4 as their marker, right? And as opposed to MAC class 1, MAC class 1 normally presents its antigen to what? Cytotoxic T cells, right? And this cytotoxic T cell, they have what? CD8, right? Marker, right? Which we're going to talk about in details when we get to immunology. So this antigen presenting cell, the alveolar macrophage, is going to now present the antigen to what? Is going to present the antigen to T cell, right? And then which T cell are we talking about here? So that's going to be what? T-helper cells. So I'm going to present it to T-helper cells, right? And on these our T cells, of course, we have what? We have the CD4, right? And then this T-helper cell now is going to differentiate into what? Into T-helper 1 cells. So to differentiate into T-helper 1 cells. And what cytokines facilitate this differentiation? So interleukin 12 that come from the macrophages. So interleukin 12. Another one that will also help is also interferon gamma, right? So interferon gamma will also what? Facilitate the differentiation. So that's why if somebody have interleukin 12 receptor deficiency, that means they can't form T-helper 1 cells and they will not be able to form granuloma. And that's why those patients can be predisposed to what? Disseminated mycobacteria infection. So this T-helper 1 cell now is going to release, it can release interleukin 2, right? And also, it's also going to release what? Interferon gamma, right? So interferon gamma. So this interleukin 2, right, could help with proliferation of the T cell. So interleukin 2 will cause proliferation of T cells. So you want to allow the T cell to proliferate. And this interferon gamma, guys, is going to now go and activate the macrophage. So interferon gamma will go and activate what? The macrophage, right? And then once it activates the macrophage, right? So you want to activate this macrophage, and this macrophage will start to produce some cytokines. And this macrophage now is going to change its form, right? So, and that's going to change its form, like we mentioned earlier, is going to now become what we call epithelioid cells. So, because they look like what? They look like epithelia. So this activated macrophage will become epithelioid cells, right? And then this macrophage will also, this activated macrophages, right, will also be releasing what? Tumor necrotic factor, right? Alpha, so TNF-alpha. And then this TNF-alpha, right? This TNF-alpha now is what is going to maintain the structure of the granuloma. So this macrophage now, so their goal now is to go and wall off this what? They're going to try and phagocytose and then wall off this what? And wall off this mycobacteria infection. So at the end of the day, you're going to have all those macrophages, right? Phagocytosing this what? Infection, and then walling it off, right? And around this area, other thing that you're going to have around this area, you're also going to have your what? Your lymphocyte. And which lymphocyte? The T-alpha-1 cells will also be there. So we're going to have T-alpha-1 cells. And in addition to that, what else are we going to have that we also mentioned earlier? When you activate a lot of macrophages, those macrophages are going to fuse together. So when they fuse together, we're going to call them what? Multinucleated giant cells. So that will also be seen around there. And then lastly, because of the chronicity, fibroblast is also going to be activated, right? And that fibroblast now is going to try and form what? Fibrosis around this what? Around this granuloma. So we're going to try and form fibrosis around the granuloma. And then with time, because of the chronicity and because of the necrosis that's going on here, calcium could deposit there. So you could have deposition of calcium in this area, right? And at the end of the day, that granuloma could become what? Calcified. So this is going to be what we call granuloma. And that granuloma could become what? Calcified. And this type of calcification is going to be called what? Dystrophic calcification. So dystrophic calcification is when you are depositing calcium in a necrotic tissue, right? And so what maintains this granuloma is going to be what? Remember, we mentioned it earlier, is going to be your TNF-alpha. So the TNF-alpha is what's going to maintain the what? Granuloma. So that's why before you start any patient on TNF-alpha inhibitor drugs, you have to make sure they don't have a latent TB. Because if you have a latent TB and you're inhibiting the TNF-alpha, that will lead to breakdown of this granuloma. So let's go back to the notes. Let's see what we have in the notes, right? So looking at the notes, so persistent antigen, like we mentioned, so we use TB as an example. So the macrophage phagocytoses but cannot destroy it. And the macrophages present the antigen on MHC class 1, right, to CD4 T cells. And the CD4 T cells differentiate into CD4 T-alpha-1 cells by interleukin 12. And T-alpha-1 cells secrete interleukin 2 and a TNF interferon gamma. Interleukin 2 produce more T cells, so it causes T cell proliferation, and the interferon gamma leads to macrophage activation and transformation into epithelioid cells, right? And the fusion of macrophages, they can fuse together, and that could lead to multinucleated giant cell. And the activated macrophage releases TNF-alpha, and the TNF-alpha is released, and that's what maintains the granuloma structure. And a fibroblast activated, that leads to fibrosis around the granuloma over time. And like you said, this is a form, because if you look at this reaction, no antibodies involved. This is purely T cell. And this is a form of what we call type 4 hypersensitivity reaction, which is a delayed type of hypersensitivity reaction. And then once we get to immunology, we're going to talk in details about hypersensitivity reaction. So let's now look at some clinical correlation, right? So like we mentioned earlier, if somebody is taking TNF-α inhibitor drugs, like we mentioned, remember TNF-α is what maintains the granuloma. So if somebody is taking TNF-α inhibitor drugs, for instance, like infliximab, adalimumab, or etanercept, that could lead to breakdown of granuloma. So if the patient has a TB, that could lead to reactivation of tuberculosis. Also, if somebody have interleukin-12 receptor deficiency, that could lead to decrease in TNF-α cells, right? And that will lead to decrease in interferon gamma production, like we said earlier. And that could lead to disseminated mycobacterial and fungal infection. And the one thing that is classic about this granuloma is that they could produce 1-alpha hydroxylase. As we know, right, in the liver, when you look at vitamin D undergoes 2 hydroxylation, one in the liver. So in the liver, the first hydroxylation by 25 hydroxylase, that will hydroxylate them and we're going to produce 25 hydroxy vitamin D, right? And this is going to now go to the kidney, right? And in the kidney, the 1-alpha hydroxylase, so the 1-alpha hydroxylase will help us to hydroxylate it again into, so that now we're going to have 125 dihydroxy vitamin D, and this is going to be the what? The active vitamin D, right? So that's why patients who have granuloma, like things like sarcoidosis, they normally have increased 1-alpha hydroxylase activity, and that could lead to hypervitaminosis D, and this could lead to what? Hypercalcemia. So that's why those patients have what? Hypercalcemia, increased calcium. So in patients who have granuloma, they could have increase in 125 dihydroxy vitamin D. Other clinical correlation that we can also talk about is QuantiFERON test, right? Or QuantiFERON Gold test, right? So what's this test looking for? So this test is actually checking for what? Interferon gamma release assay. So our interferon gamma, right? So that's what this test is what? Measuring. So this is a blood test used to detect latent or active mycobacterium tuberculosis infection by measuring what? Interferon gamma release from sensitized T cells. So what you do, you take the blood from the patient, and when you take the blood from the patient, then you expose them to antigen, like TB antigen. So if you expose them to TB antigen, so let's say that patient has been exposed before. Remember, we mentioned earlier that when the patient is exposed to an antigen, right, the antigen presenting cell takes it up and eventually present the antigen to what? To T-alpha cells, right? And that T-alpha cells is going to differentiate into T-alpha 1, right? And then some of these TNF-α 1, some of them are going to become what? Effector cells, right? Effector cells, which we're going to talk about when we get to immunology. And then some of them are going to become what? They're going to become TNF-α 1, but memory cells. So the memory cells are going to keep the memory for the future, whereby the effector cells, they're going to go into circulation and go and act, right? So this memory cell now, so if a patient has had a latent TB in the past, right? If they have had a TB and it has become latent, right? If they have been exposed in the past, right? Then that could create what? That could create a memory T-alpha 1 cells. So when you take the blood, and in the blood, this patient have the memory T-alpha 1 cells, by the time you introduce this antigen, then that's going to activate these memory T-alpha 1 cells. And that's going to start releasing what? Interferon gamma. So they want to start releasing interferon gamma. And then you can measure that. And that's what we measure with QuantiFERON what? Gold, right? So if the patient has been infected with TB in the past, then the memory T cell will release what? Interferon gamma, right? And the other test is also what we call T-SPOT. So T-SPOT is also another test that we can use to check for latent or active TB. So this is also similar to QuantiFERON test. But in T-SPOT, what you are doing, instead of checking for the release, what you're actually doing, you are counting the individual T cell that are releasing the interferon gamma. So that's what you are counting. So you are counting individual T cells that release interferon gamma in response to the TB specific what? Antigen. And both tests measure the cell-mediated immunity. So when you talk about cell-mediated immunity, we are talking about things like TNF-α and cytotoxic T cell, which we're going to talk about in immunology. But these tests, they are checking for your cell-mediated what immunity, particularly the TNF-α producing interferon gamma. And the cell-mediated immunity, those are the immunity that help us to deal with intracellular antigens, right? And then we also have T-SPOT test. So the T-SPOT-TB test is very good in immunosuppressed patients because that allow you to be able to count their individual T cells that are releasing the interferon gamma. So let's talk about types of granuloma. So what are the types of granuloma? So normally when you look on the microscope, remember we saw it earlier, right? So with granuloma, at the end of the day, you're going to have the epithelioid cell, like we mentioned. So you're going to have some epithelioid cell. And in addition to that, you will also have what? Multinucleated giant cells, right? Being formed. So epithelial multinucleated giant cell. And they're going to have TNF-α cells around that area. And they're going to have fibroblasts around the what? Around the area, right? So at the end of the day, you're going to end up with this what? With this granuloma, right? So when you look at the granuloma, so it's an organized activated macrophages that are called epithelioid cells and often surrounded by your CD4 T helper cells, right? Fibroblasts and a multinucleated giant cell, which are fused what? Macrophages. So when you look at this granuloma, so this granuloma could be caseating granuloma. So which now lead us to now talk about what? Caseous necrosis. So that's why I decided to talk about caseous necrosis and granulomatous inflammation together. So caseous necrosis. So what's caseous necrosis? So in caseous necrosis, it's also under granulomatous inflammation. So what we see here, so because the granuloma is so big, right? So because you have a granuloma there, and so what happened is that the center of the granuloma, right, because they're not getting enough blood supply. So when you look at the center of the granuloma, because they're not getting enough blood supply, because remember, they're far away from the blood supply, they are in the center. So because they're not getting enough blood supply, so they're not going to be getting enough oxygen. And also because of free radical production, those central area, they're going to start to die. So there's going to be necrosis going on, right? And as this necrosis is going on, right, then those mycobacteria or systemic fungal, so the mycobacteria tuberculosis or the systemic fungal, their cell membrane will start to break down. So we start to break down their cell membrane. And the cell membrane of the mycobacteria tuberculosis is very rich in what? It's rich in lipid, right? Whereby same thing with the systemic fungal is also rich in what? Lipid. So as you are breaking them down, then that's going to form a what? A caseous or a cyst-like what? Appearance. And that's where that name comes from, the caseating what? The caseating granuloma. So you're going to form all those cyst-like appearance, right, in the center of the granuloma. So caseous granuloma or caseating necrosis. So caseous cyst-like or crumbling white granular acellular material located in the center of the what? Granuloma. And then look at it. So low oxygen in the center of the granuloma and the free radicals, right, leads to necrosis and release of lipid from the cell walls of the mycobacteria tuberculosis and systemic what? Fungal. And that leads to caseous material in the granuloma. So classically, the mycobacteria tuberculosis and systemic fungal, they normally cause what? They normally cause caseous what? Granuloma or caseous necrosis. So moving on to non-caseating. So basically what non-caseating means is that you don't have the central what? There's no central necrosis there, right? And then this non-caseating could be seen in a lot of them, like things like sarcoidosis, Crohn's disease, and Tuberculosis, and a couple of examples that we mentioned earlier. The other thing I also want to mention in patients we have with sarcoidosis. So sarcoidosis classically normally cause non-caseating granuloma, right? And the granuloma will also produce angiotensin converting enzyme, which is ACE, which can be increased in the blood. And they classically normally have bilateral hilar adenopathy. So when you see bilateral hilar adenopathy, along with increased ACE level, and a non-caseating granuloma, you should always be thinking of what? Sarcoidosis. The other thing we could also see is elevated CD4 to CD8 ratio, which makes sense because CD4, right, which is our T-alpha cells, is what is implicated in formation of granuloma. So that means you're going to have high level of what? CD4 relative to CD8. So when you do your bronchial alveolar lavage, so that could also help to support the diagnosis of sarcoidosis. And when we look at this diagram, so here we can see a lot of inflammatory cell. You can see some multinucleated giant cell there. A lot of inflammatory cells around there, surrounding that area of what? That area of granuloma. So that's a granuloma right there. And then one thing you appreciate about this granuloma here, you can see in the center we have less cells in the center, and then we also have what we call caseous caseating area. So this is going to be a caseous what? Necrosis. And surrounded by epithelioid macrophages, and then we can also see some Langerhans giant cells there, right? So I think we've come to the end of today's lecture, but as usual, we're going to do some questions together. So let's look at the first question. So a 29-year-old woman presents with shortness of breath, right, and a chronic dry cough. She also notes occasional red tender nodules on her shins. Physical examination reveals bilateral cracks. We did a chest X-ray. It shows bilateral hilar adenopathy, right? Bilateral hilar adenopathy. The serum studies show elevated ACE level and hypercalcemia. Remember, we mentioned that one thing that you can see in granuloma is hypercalcemia because of increase in 1-alpha hydroxylase, leading to hypervitaminosis D. A biopsy of the lung lesion shows tight, well-formed non-caseating granuloma composed of epithelioid cells surrounded by what? Lymphocytes. And what type of lymphocyte is that? TNF-α cells, right? Which of the following immune pathways is most likely responsible for the formation of these lesions? So what do you guys think? Right? The same pathway for all granulomas. So the best answer there would be what? C. So TNF-α cell releasing interferon-γ, activating the what? Macrophages. And the macrophage is going to release what? TNF-α, right? Moving on to the next question. So a 47-year-old man immigrated to the United States. Sorry, I moved too fast. Immigrated to the United States 2 years ago, present with worsening chronic cough and weight loss. Physical examination reveals enlarged cervical lymph node. A biopsy of one of the nodes shows epithelioid macrophages and a multinucleated giant cell surrounded by an amorphous eosinophilic acellular debris. So we did a stain, right? Zil-Nelson stain that reveals red slender bacilli, right? Which is what we use for what? Mycobacteria tuberculosis, right? Which additional histology feature will most likely be seen in this patient? So this patient has Mycobacteria tuberculosis infection, so classic history, right? And then with Mycobacteria tuberculosis, what are we going to see? It can cause caseating necrosis, right? And the best answer there will be what? Will be B. So central caseous necrosis due to hypoxia and free radical damage, right? So last question, guys, we're almost there. A 34-year-old man presents with chronic abdominal pain, right? Non-bloody diarrhea and weight loss. So somebody is young, right? Abdominal pain, non-bloody diarrhea and weight loss concerning. So colonoscopy show patchy area of inflammation throughout the terminal ileum and ascending colon. So it sounds like something that is jumping, skipping, right? Skipping lesions. Biopsy review transmural inflammation and non-caseating was granuloma scattered throughout the intestine. So this classic presentation is concerning for what? Crohn's disease, right? This is a classic presentation of Crohn's disease. So which of the following findings is most likely associated with this patient condition? So because of the transmural inflammation, so if somebody is having transmural, so when you look at the intestine or the colon, there's an inflammation throughout the wall. So because there's transmural, so this inflammation could also what? Affect adjacent intestine. And that could lead to what? Fistula formation. So both of them could now form, they could now join together and form a what? Fistula. So I think the best answer there would be what? Perianal fistula formation. And as a matter of fact, Anytime you see a young, what's called an individual, very young individual that is having maybe perianal fistula or fistula in the body, one of the things that you should always think about on the exam is Crohn's disease. Guys, it's been a long lecture. We've come to the end of today's lecture. Please don't forget to subscribe, share this video with your friend, and I will see you in the next video. Thank you.